Without further ado, I am very happy to introduce our clinical speaker for today, Dr. Jocelyn Rapelyea. She is the Vice Chair of Education and Director of Radiology Residency Program of the George Washington University Hospital. She was also a sub-investigator in the SOMO Insight study, a prospective multi-center clinical study that compared the sensitivity of full-field digital mammography alone versus combining ABUS with mammography for screening women with dense breasts. Dr. Rapelyea, I will hand this session to you.
Hello, everyone. I just wanted to welcome you to today. I'm going to be speaking to you about the role of screening breast ultrasound and really our experience that we've had with 3D. One of the things that I will be going over, is really the backbone of where we started and then what some of the data has come in the last decade or so. So I am going to minimize my camera. And hopefully everyone will be able to see my screen shortly. Okay, wonderful. Okay, so the one thing that we will be discussing today are the benefits of screening breast ultrasound. We'll review, as I said, some of the data, and of course we'll be reviewing the 3D ABUS platform. When we talk about breast cancer screening, there's really three objectives that it should have, and that's one, the ability to diagnose early breast cancer. Two, to find curable and small cancers. And then three, this really kind of translates the smaller cancers that we wind up identifying, really translates into the reduced cost for advanced disease, which would include surgery as well as neoadjuvant chemotherapy and radiation therapy. So mammography, I believe that, we always speak about mammography as really our mainstay for breast cancer. And part of the reason is, as a screening tool, it does the job of what it's supposed to do. And that really is find those small cancers and also find early breast cancers as well. It also is the only screening modality that is proven to reduce mortality. And we know this from the randomized control trials. Although the randomized control trials were done a few decades ago, it really has established the benefit for mortality reduction. And part of it has to do with removing the biases that are inherent in some of the observational studies that we know. The magnitude, though, of the observed benefit of randomized control trials is really underestimated, and that really is multifactorial. Most of the underestimation has to do with contamination or invitation. So if we have two arms, one that is invited for screening, if women decide that even though they're in that invitation arm, whether to get screened or not, those that are non-compliant will weigh down the benefit of those that are considered invitation to screen. Also, contamination, women that are not invited to screen but do decide to get screened outside of the trial will contaminate the results for those women that are again considered to benefit or not benefit from a screening study. Though also the difference has come in the last few decades, it's really our technology. Most of, I would say, here in the Western region are moving towards digital breast tomosynthesis. Here in the States, we have almost 50% of all of our mammography centers have digital breast tomosynthesis. At George Washington, we are fully showing these patients, or screening these patients rather, with digital breast tomosynthesis. We don't even take the 2D images. We actually use the synthetic view. So this all plays as well into the potential underestimation of the benefit because our technology has improved significantly. And we know this from some of the trials that have been done, that tomosynthesis can improve our overall detection for early breast cancers and small breast cancers. During the time of when the randomized control trials were done, I would say that there were some of the concerns as to whether it was 1 or 2 views that were actually being performed in order to screen these women. And then also the intervals may have been too short of a period of following these patients, and the recall rate was actually a little bit too low. Some of the recall rates were less than 5%. So the effectiveness of population-based screening really should look at a couple of the mainstream things that are occurring currently. So of course, that would be, as I said, digital breast tomosynthesis, but also how specialized that we've become in breast imaging. I would say probably 4 decades ago was the general radiologist, but now more and more people are fellowship trained, and they're also dedicated just for breast imaging, which improves overall our sensitivity, we know, in order to be able to find those small cancers. There's also been improved treatment as well in our ability to be able to combat breast cancer, thereby reducing some of the mortality associated with breast cancer. If we look at our national database, it's called SEER database, which is the Surveillance and Epidemiology review of all of our cancers that we have. Specifically for breast cancer mortality, we know that when we started to implement screening mammography in the early 1980s, you can see a slight increase overall in the next 10 years. And that's really because we were identifying some of those prevalent cancers as well as the incidence cancers. And it takes about 10 years to show, once you implement a study, to show a benefit. And when you look at 1990, you can start to see that benefit occurring because the reduction in the mortality rate significantly decreases. Overall, if we look at the data up until 2014, it's about 38% reduction. But if we actually add 2000 up to 2017, which is just only a couple of years ago, we now have a 40% reduction in mortality. This also was evaluated by the American Cancer Society when they came out with their new guidelines. And there were a couple of things that they looked at, particularly with these histograms marked A and B, so the one all the way to the left and the one in the middle. You can see that the distribution of new breast cancer cases by age significantly increases from 40 to 44 age subset to 45 to 49. And it was really this significant incremental increase that really started to come into play for many of the different society guidelines. The American Cancer Society believes that definitively you should definitely begin screening at age 45, but in order to maximize your benefit, beginning at the age of 40, so a few years before that, before you get to that significant incremental increase, is what should be noted. The other thing with the American College of Radiology, because there is this significant uptick from 44 to 45, they believe that you should start again earlier, usually 10 years earlier, in order to be able to glean as many patients as possible. Well, we do realize that we want to minimize our risk, we want to increase our benefits. So the happy medium was around the age of 40 years of age. And we recommend annual screening with mammography beginning at 40 so that we can, again, capture as many cancers as possible. Of course, you could start screening at 25 years of age, but really when we start to look at the histogram and the number and the percentage with the risk outweighing the benefits, 40 is probably the optimal age for us here in the Western Hemisphere. As you can see in B, where it's showing the distribution of breast cancer deaths by the age at diagnosis, beginning at that age of 45. So in that 5th decade, we can see a significant uptick of the number of deaths. So again, if you start approximately a decade earlier, it allows you to be able to decrease that risk of having those deaths and finding more curable cancers. Well, how does this translate actually for the Arab world? If we look at a new study that came out that looked at really the epidemiology of all of the cancer incidents in the Arab world, it follows a similar trend where we look at the gray as global, so world versus that of in the Arab region. And we can see earlier on, around the age of 35 to 39, there is a larger incidence in the Arab world versus that of globally. And this trend continues till you get to about 45 years of age to 49, where it's comparable to that of the rest of the world. And then you can see that the overall incidence really is less than that of the Western world in the region compared to the Arab region. And that is really a trend that continues throughout lifetime. Now, if we look, the difference really in some of this data versus that of data that was previously published, where it looked at the median age or the average age, it shows around 48 or 44 in some regions, where that is the median age or the average age. However, looking at the median or the average age doesn't help with the statistical analysis of really the breakdown in the decades that you have of the patient population. It looks like the Arab world is much younger society versus that of the Western part of the hemisphere. And for that reason, if we go back and look at the data where it shows, even though the incidence is a little bit higher, you can see the p-value is not statistically significant because this is looking at age-adjusted incidence. So if you really look at it weighted on age and knowing that you have a younger population and adjusting for that, the trend is really kind of comparable, as you can see that trend going up to about the age of 50, and then it kind of levels off, where then it becomes beyond the menopausal stage. It starts to become statistically significant that it's lower than that of the rest of the global hemisphere. But what we do realize, though, is that overall, whether you're dealing with the Arab region or whether you're dealing globally, that the trend is increase in the incidence of breast cancer. And this is projected to significantly continue to increase for everyone as we get older and show that there's going to be more potential breast cancer deaths. So the only way really for us to reduce our risk of having breast cancer death is to undergo screening. For us here in the States, we do yearly. Our European counterparts actually wind up doing every other year, but we do know the more that you screen, that you can overall reduce the incidence, the size, as well as the metastatic rate of breast cancer and how this translates into the mortality of breast cancer. Dense breast tissue is one of the factors that, particularly if you do have a younger population that is developing breast cancer, something that you would have to deal with as a risk factor. We know that it is an independent risk factor, and we also know that it is one of the things that should be considered for supplemental screening, because as radiologists, it's very difficult to be able to detect a breast cancer in mammographically dense tissue. Now, there are a multitude, if we get a broad spectrum of what risks are and categorize them. Personal related breast cancer risks are things that we can potentially change, which would have to do with the patient's BMI or hormone replacement therapies, sedentary lifestyle. But some of the things that we can't change, which are breast related, of course, are prior biopsies that are demonstrating some type of proliferative atypia, and then of course dense breast tissue on mammography. Now you can see that where this ranges, the dense breast tissue on mammography versus that of having genetic versus that of personal risk factors, that it really puts you directly in the middle. So it gives you that intermediate risk of developing breast cancer. And if we look at the data, it also has a higher risk of interval breast cancers, about a 17.6% odds ratio risk of developing an interval breast cancer. Now, unfortunately, interval breast cancers, as we know, have a worse prognosis, and we would have to have more extensive resources, medical resources, in order to cure patients with interval breast cancers. But also, it can add to the mortality rate for breast cancer. So these patients that wind up having dense tissue or at intermediate risk is really, for us, was the greatest debate here in the Western Hemisphere as to how we should supplement our screening. And here in the States in particular, there are really a push towards either ultrasound or MRI, with MRI being, of course, the more expensive option, and ultrasound not requiring an injection and also being more readily available. More and more people are adopting ultrasound screening. And if we look at, again, the new BIRADS, or the new, I should say, ACR lexicon with the BIRADS density, we know that we are trying to capture as more people that should have a supplemental screening with ultrasound or MRI than those that are just having mammography alone. So these are just two patients that are considered heterogeneously dense versus that is extremely dense, but really both categories would benefit from the addition of having supplemental screening in order to glean as many cancers as possible. There's now software, of course, that really allows us not to do this in a qualitative way, but more in a quantitative way. And they have adopted the new lexicon with the BIRADS density, which is really looking more or less at the confluence of shadows that can potentially decrease our overall ability to be able to pick up a breast cancer. So really, what are the factors that are involved in a false negative mammogram? A lot of it has to do with patients that particularly have dense breast tissue. You have overlap of normal cancer as well as with normal dense tissue, which then can lead to mischaracterization of a finding as well as misinterpretation. If we wind up supplementing with that of additional tools, we could potentially pick up additional cancer. So this is an older case, it's just showing, I think everyone can see the spiculated mass that's within the right axillary tail that's overlying the pectoralis muscle. But, you know, if you had a cancer that was closer down within the glandular tissue, it would be a little bit harder. And that really is because you lack that contrast resolution that occurs. This is where the second cancer was. So again, it makes it difficult if you have adjacent glandular tissue that is the same density as that of regular normal normal tissue versus that of cancer. So the one thing that we do know that has been very helpful is full field digital mammography, and now also with the advent of digital breast tomosynthesis, we can glean more cancers because we can see more characterization between that of the actual glandular tissue and that of cancer. The Astound trial actually demonstrated to us that all comers, you would really wind up having the potential to be able to pick up additional cancers. However, in those patients that wind up having extremely dense breast tissue, the digital breast tomosynthesis did not fare as well. But for each of the modalities, if we looked at ultrasound as well as breast tomosynthesis independently, they yielded additional breast cancers. And ultrasound, though, led to a significantly higher incremental breast cancer detection than that of tomosynthesis. And it really was because of the category D, or the highest breast density. So if we look overall, tomosynthesis had detected approximately half of the additional cancers identified through the addition of screening with dense breast tissue, whereas ultrasound detected almost all, okay? And they had similar false recalls for the two modalities. So with their findings, what they really came up with is that the probably benign category, which were not recalled for workup but recommended for short interval imaging review, was really more so due to tomosynthesis, and compared to that of ultrasound, which was really only 1.8% of the screens for the additional review. For their really conclusion in their discussion, what they recommended is that as an adjunct screening study for women that wind up having dense tissue, ultrasound as well as tomosynthesis could actually potentially identify additional cancers, and that if we look at ultrasound as an independent, though, it probably fared well overall compared to that of digital breast tomosynthesis. So again, looking at dense breast tissue, although we've come a long way with that of mammography, it really winds up hitting a roadblock when it gets to that extremely dense breast tissue, only because you lack the contrast resolution. We do have that though for ultrasound, where really breast density, there's really no need to determine what kind of breast density, because we can still glean those or capture those cancers on that modality. Ultrasound, as we know, is, really probably the most common adjunctive study that is used in problem solving. It also is one that we use for diagnostic evaluation to determine whether we're dealing with something that is more solid in appearance versus that of cystic. But really, as we know it and what the emerging indications have been, is screening tool for mammographically dense breast tissue. Now, some of the limitations that we have of really just putting screening breast ultrasound out there is that if there is no reproducible way, that you can have a variety of descriptive terms that wind up having a lesion that you wind up seeing. And this has to do with really the inconsistent technique that you can get from one place to the other, or really how the radiologist likes to view their images. Both of these images here show cancers, and one has a little bit more speckle reduction versus that of the other. And you can see that the one particularly all the way on the left, it looks more anechoic than anything with enhanced through transmission. But I think what would tip us off is really the factor of the orientation of the growth of this lesion. It would be suspicious enough. However, again, if we were just looking at it from an anechoic versus that of a solid or a cystic finding, you would think that the one on the left is more cystic. But again, this has to do with the differences in the machines, as well as, how radiologists view their images as well. What we would like is really, particularly for ultrasound as an adjunct study in this patient population, to find more cancers. And we have found that using just screening handheld. And this was Tom Colt's paper a couple of decades ago that showed that women that were at higher risk, when they wind up having an addition of ultrasound, they found 42% more additional cancers. And this was, really one of the first studies that everyone said, well, maybe we should be adding ultrasound for the addition of looking at breast cancers in this patient population. The one thing, though, that we weren't sure was pretty reproducible was his mean time for looking at screening ultrasound. And that was around 3 minutes and 59 seconds, so an average of 4 minutes. And if we look at the other studies, and particularly the clinical trials and the multi-institutional studies, that did not pan out. And I think the other opposite end of the spectrum was the Akron 6666 trial, which showed an average time of 19 minutes. Now, needless to say, this was per protocol, and they had to do a significant number of measurements if they wind up seeing something that was abnormal. But again, we can see the different spectrums of what it would take in order to make sure that you were properly looking at everything, and also feeling confident that you were being able to pick up those additional cancers. So we do know from screening breast ultrasound that the data does support that we do find additional cancers. However, the time as well as the expertise really is something that should be considered when implementing a screening program. The one thing that ultrasound does have going for it, again, as I said, it's widely available, but it also is no ionizing radiation and no injection, with the ability to be able to pick up more cancers. So this is where the wide field of view, which is something that is more reproducible, was thought to be one of the answers to the questions that needed to be had. So with automated ultrasound systems, you're allowed a couple of things, and not only really a larger field of view compared to the handheld, smaller 4-centimeter transducer, but the